name is Jessica Hubbard, and I am a manager for the Community Education Department at MDA. We are thrilled to have you join us for MDA's virtual learning series on Duchenne muscular dystrophy. We look forward to seeing you on December 11th for the live Q&A session with all of the presenters from the series. This learning series is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. MDA would like to thank REGENXBIO for supporting this virtual learning series. And then for nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers this mission through research, care, advocacy, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. MDA funds projects throughout the drug development process, from early discovery through translational stages and infrastructure support for clinical trials. MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. And then MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare treatments, independent living, newborn screening, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with rare neuromuscular diseases. And then our community education and recreations programs are designed to connect individuals and families. We're committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. In 2023, we offered over 40 educational programs, over 20 summer camps, and dozens of other community activities for both in-person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free, and please see the link that will be at the end of the presentation. To learn more about MDA, please visit mda.org. Now it is my pleasure to introduce today's speaker, Dr. Hayes from Nationwide Children's Hospital in Columbus, Ohio. Dr. Hayes is a muscular dystrophy and transplant cardiologist at Nationwide Children's Hospital. She currently serves as the medical director of cardiomyopathy and is the cardiac director of the neuromuscular program. Her clinical and research interests include improving long-term outcomes following heart transplantation and the care of cardiomyopathy in patients with muscular dystrophy, including the use of advanced cardiac therapies. Thank you for being here today, Dr. Hayes. I will now hand things over to you.
Thank you for that kind introduction. As Jessica said, I'll be presenting on cardiac care in patients with dystrophinopathy. So today, I'd like to briefly overview the disease process itself, talk a little bit about the cardiac involvement, and then really focus on the cardiac assessment and then the treatment options for cardiac disease. Dystrophinopathies are a group of neuromuscular diseases that result from mutations in the structural cytoskeletal dystrophin gene. So this includes Duchenne muscular dystrophy, Becker muscular dystrophy, and includes dystrophinopathy carriers. And it really manifests as progressive muscular weakness. This is the historic timeline of the progression of DMD. In the first 3 years of life, infants and young boys show measurable weakness in both gross and fine motor function. At age 5 years, there's prominent muscle weakness. And as they continue to get older, there's a loss of ambulation and a need for non-invasive ventilation, particularly at night. In the second and third decades of life, advanced respiratory and cardiac complications lead to mortality. However, over the past several decades, there's been a large focus on providing multidisciplinary care. And so this has really changed that timeline and has really brought to the forefront the cardiac complications that we see in DMD. So what do we know about DMD in the heart? We see in these patients fibrofatty replacement of the myocardium or the heart muscle that results in a cardiomyopathy. The incidence of cardiomyopathy increases with increasing age, with 25% having cardiomyopathy by 6 years of age, 59% by 10 years of age, and over 90% of patients having a cardiomyopathy by 18 years of age. So you can see from a cardiac standpoint, patients start with a normal heart, they develop fibrosis or scarring with preserved LV function or LV squeeze. And then as that scarring continues, the LV does not work as well and it becomes dilated or enlarged. This results in end-stage heart failure. So what does my heart look like? So on echocardiogram, you can see on the left-hand side, this is what a heart with normal function looks like. And then on the right-hand side, this is an echocardiogram of a patient who has decreased function. So you can see it doesn't squeeze as well, and the muscle isn't as coordinated. Another way that we look at the heart, which we'll discuss in a little bit, is by cardiac MRI. So on the left-hand side, we can see this whiteness to the heart muscle compared to the blackness up here, which is normal myocardium, with the white being fibrosis or scarring. And then looking under a microscope at the muscle itself, again, we see fibrosis or this blueness that's stained here representing scarring of the heart, whereas the pink is what normal heart tissue. The clinical manifestations are really difficult to discern in patients with muscular dystrophy. So cardiac signs and symptoms occur late in the course of the disease and are really difficult to separate from skeletal and respiratory symptoms. Some patients will have shortness of breath or coughing. Some will have fatigue. If they're still ambulatory, they can tire easy with activity, or if they're non-ambulatory, they need to rest more often throughout the day. Some have poor appetite, nausea, vomiting, and abdominal pain, particularly with eating. And then some patients also have swelling. The cardiac and the neuromuscular disease severity do not correlate. So we've had some patients who have pretty significant cardiac disease but are still ambulatory and vice versa. So how should we screen for cardiac disease in this patient? So all patients with DMD should have a visit with a cardiologist at least once a year, and then more frequently once there is no cardiac involvement. That evaluation should include an EKG and an echo or a cardiac MRI, and then female carriers should be seen at least every 3 to 5 years. At these visits, there will be different types of clinical testing. So from an imaging or evaluation of heart function standpoint, it can be an echocardiogram or cardiac MRI. There should be a rhythm analysis, so an electrocardiogram, also known as an ECG, and then an ambulatory ECG or a Holter or Zio monitor. And then finally, we do get laboratory studies, which include a troponin, a BNP, and a BN. So for the echocardiogram assessment, this is an ultrasound of the heart that's used to assess heart function. It cannot detect the scarring that can only be seen by cardiac MRI. It is able to be obtained relatively quickly in clinic, but it is difficult to acquire quality images, particularly as patients get older. So again, you can see the top picture is normal function, how the heart squeezes together. And then the bottom image shows decreased function. Again, the heart's not as coordinated and not squeezing this. Another way to evaluate the function is by a cardiac MRI or magnetic resonance imaging, and this is performed typically in the radiology department in the hospital. It can assess the function and for the presence of scarring or fibrosis. It does require an IV to determine the scarring or fibrosis. In younger kids, it may require anesthesia. It is a longer test for them to be able to face it. Next is rhythm monitor. Most patients should have EKG once per year. It's a 10 to 15 second snapshot of heart rhythm, and it's able to be obtained relatively quickly in the clinic. And then there's ambulatory EKGs, which are a Holter monitor seen in the middle or a Zio patch on the right-hand side. And these allow us to look at the heart rhythm for 24 hours all the way up to 14 days. And these can also be easily applied in clinic, but do take longer to get the results. Laboratory studies that we often look at in patients is a troponin. This is a protein that's present in the heart muscle and it's released when the heart is injured. A basic metabolic panel, or a BNP, and this looks at the electrolytes in the blood and the renal function. And then finally, a BNP, or brain natriuretic peptide, and this is a hormone that's released by the heart to communicate to the kidneys on salt and water removal. And this is elevated when the heart is not functioning properly. Action is a learning network of pediatric cardiologists, and they have an arm devoted to muscular dystrophy. And they have many handouts that I find are very helpful to patients to have, one of which is a progression tracker. And so this progression tracker, for those of you that like to take notes during your visits, has sections for fibrosis or scarring. It has a section for recording your ejection fraction or the percent squeeze of the heart, a section for heart rhythm, and then a place to write medication changes at the bottom. So moving on to medications, I typically separate them into two categories: preventative or prophylactic medications when the heart function is normal, and treatment medications for when we've seen a decline in function or if there's any scarring present. So starting with our preventative medications, the first one is glucocorticoids or steroids. So this is a standard of care in muscular dystrophy. It slows the progressive decline in skeletal muscle and pulmonary function, but it also delays the onset and progression of cardiomyopathy. And we know this is a great long-term medicine for patients to be on as it improves overall survival. The next preventative medication or class of medications are ACE inhibitors or angiotensin receptor blockers. This includes enalapril, lisinopril, captopril, and losartan. And these block that communication between the heart and the kidneys that leads to fluid accumulation. They also lower the blood pressure and can slow fibrosis or scarring. The side effects we most commonly see with these medications are dizziness due to a lower blood pressure, cough, and renal dysfunction. The next preventative medication we typically use in these patients are mineralocorticoid receptor antagonists, which is really hard to say, so we say MRA, which includes eplerenone and spironolactone. We also refer to these as potassium-sparing diuretics, but they do have a slight diuretic effect. They also block the communication between the heart and kidneys that lead to fluid accumulation, and they slow fibrosis formation. The biggest side effect with these medications is high potassium, and so the physician will likely want to check a BNP to make sure that that is not occurring on this medication. So most patients who have normal function and no evidence of scarring should be on an ACE inhibitor or ARB and an MRA. So moving on to medications that we use for treatment when we see evidence of scarring or a decline in function would be higher doses of an ACE inhibitor or ARB. And then a newer class of medications that's being used in heart failure is called an ARNI. And this is a neprilysin inhibitor and an angiotensin receptor blocker. And that additional neprilysin inhibitor ultimately helps to maintain a better salt and water balance in the body. It's called sacubitril valsartan, or the brand name is Entresto. Next treatment option would be a beta blocker. Propranolol and metoprolol are the two most commonly used. They decrease the heart rate, slow fibrosis formation, and can also treat abnormal heart rhythms. And the side effects we see for these medications is dizziness due to low blood pressure and feeling tired. So that tends to go away after a week or two on the medication. A few other medication options for treatment are SGLT2 inhibitors, which are dapagliflozin and empagliflozin. This increases the salt and sugar in urine, which can increase water removal from the body. Evaporating, which can lower the heart rate. And finally, diuretics like Lasix or Bumex. And these are really based on symptoms and are used to help patients feel more comfortable. So this is my current management for most of my patients. And so really by age 10, patients should be on an ACE, ARB, or ARNI, as well as an MRA. And so I actually start these medications on the younger side, so even down to 6 years of age. And that's so we have time to really start at low doses, get them up slowly on doses, so that we're really minimizing the side effects. And again, once we see dysfunction or scarring, we add on beta blockers, consider an SGLT2 inhibitor, and then additional therapies based on symptoms and family restrictions. The next category of treatment options for patients would be what we consider advanced cardiac therapies. So that includes an ICD, a VAD, and a heart transplant. So how do we determine if a patient is a candidate for an advanced therapy? So an ICD, or an implantable cardiac defibrillator, is typically only placed when we see signs of abnormal rhythms like ventricular tachycardia or really fast heart rate from the bottom chambers. And this implantable defibrillator can reset the heart rhythm in the slight in an emergency. Ventricular assist device are another option. It's an implanted pump to help improve blood flow to the body. And these can be implanted as destination therapy or as a bridge to transplant. And then finally, there's heart transplantation. And this is really dependent on the skeletal and pulmonary muscle involvement, as well as family and patient wishes. I encourage all of you to discuss the options that you have with your treatment team. Going back to action, this is the website that you can get to go to the action handout, myactioneducation.org. I find these really helpful, particularly when patients are first diagnosed or first starting on medications. And so the top left one is an introduction to heart failure. And it really goes through kind of the basics of what the heart does, how it works in the body, what signs and symptoms we're looking for. The next handout that we have is common medications, which will include a lot of the information we discussed today, and goes through, again, all of the monitoring that we do and all of the side effects to look for to communicate back to your team members should you be having any of those side effects. And then, as I mentioned, the progression tracker, which can really help keep track of how things are changing at each visit. So in summary, the heart is a muscle too. Cardiomyopathy occurrence increases with age, and so screening is really important to identify cardiac involvement early. Preventative treatment should be started by age 10 years of age, with more options available if dysfunction develops. Cardiac dysfunction can occur without symptoms, or symptoms can be attributed to skeletal or the respiratory system. And finally, multidisciplinary care is important for improving outcomes. Thank you.
That was wonderful information, and thank you so much for sharing that with our community. If you are new to MDA and you've been diagnosed with a neuromuscular disease under MDA's umbrella, or if you have a loved one or someone who is diagnosed, we encourage you to stay engaged with us at MDA, and you can do that by visiting mda.org/join. And then you may also scan the QR code that is on the screen. And then again, MDA would like to thank REGENXBIO for supporting this virtual learning series. And we hope to see you all on December 11th at the Q&A, where Dr. Hayes will be there to answer some questions that you may have, as well as our other presenters from this virtual learning series. We look forward to seeing you then.